Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is Advanced Disease Management in CLHIV less than 5 years of age, and the speaker is Dr. Shyamsunder Singh, sir. Dr. Shyamsunder Singh, sir, is currently working as the professor and head of Department of Paediatrics with the Regional Institute of Medical Sciences, that's RIMS, Imphal. He's also an ACO Master Trainer and involved as a resource person in many trainings conducted by COE RIMS. He has published numerous papers in international and national journals. We welcome you, sir, for today's session and request you to start the session.
Thank you, madam. Good afternoon to all. Continuing with the Regional Distance Learning Seminar Series on HIV care and treatment, today's topic will be Advanced Disease Management in children living with HIV in less than 5 years of age. The objectives of this session are measure causes of morbidity and mortality in CLB, understanding them. What are the packages available for advanced disease management in CLHIV under 5 years of age, and the treatment of tuberculosis in CLHIV. WHO defines advanced HIV disease for adults and adolescents and children 5 years or older as having a CD4 cell count of less than 200 cells per cubic mm, or who clinically stage 3 or 4. All children less than 5 years who are not already receiving ART and clinically stable are considered to have advanced disease because evidence shows that 80% of children less than 5 years who are not already receiving ART and clinically stable have severe immunosuppression, and these are considered to have advanced disease, and these entail high mortality in them. And Indian data published in 2016 showed that 20.2% of children less than 5 years of age are already having with advanced disease, and 38.6% had advanced WHO clinical staging, 38.2% were severely immunosuppressed, and 22.3% were severely malnourished. In fact, all of these CLHIV children, they are found to be malnourished, as we see or encounter them here also. So advanced HIV disease entails newly diagnosed CLHIV as less than 5 years, severe immune suppression following treatment failure, re-engaging with care after treatment interruption. Sorry. Please note that children older more than 2 years of age and who are on ART, they are said to be clinically stable. What are the major causes of morbidity and mortality in HIV-infected children? First of all, pneumonia, including PCP, pneumocystis, gerobacter pneumonia, tuberculosis, bloodstream infections, diarrheal disease, severe acute malnutrition. We will see them one by one. And in Indian study published showed that 38% had pneumonia, including PCP, 20% had tuberculosis, 20% had sepsis, and 10% had diarrheal disorders. What are the packages of advanced disease management in CLHIV under 5 years of age? Evidence on ADM package for children. 2017 guidelines focus on providing enhanced package of prophylactic, diagnostic, and therapeutic interventions for those starting ART with advanced HIV disease. Data informing these guidelines are from adults in 2 trials, REMSTART and REALITY. REMSTART stands for Reduction of Early Mortality Among HIV-Infected Subjects Starting ART, and the REALITY stands for Reduction of Early Mortality in HIV-Infected Adults and Children Starting ART. REMSTART only enrolled participants older than 18 years of age. In the REALITY trial, only 4% of the participants, 72 of 1,905, were 5 to 17 years old and received the same package of prophylactic interventions as the adult group. Evidence on the management of advanced HIV disease, specifically related children, they are limited, and there are no randomized controlled trials available under 5 years years of age. These data are available on the website. One can go through them if desires so. The affected children should be offered advanced disease package and evaluated for pneumonia at every possible visit, tuberculosis, bloodstream bacterial infections, diarrheal disease, and nutrition. There are no existing randomized controlled trials to include children to determine the optimal care of package of care for advanced HIV disease for children. But interventions are available in the form of stop AIDS. They are screen, treat, optimize, and prevent AIDS. So what are the interventions? Screen. First one will be for tuberculosis. Screen for TB using a clinical algorithm followed by X-ray when indicated, and if available, use the following diagnostic test to confirm TB as applicable. Rapid molecular diagnostic expert or MTB or ultra on induced sputum, stool, gastric aspirate, or nasopharyngeal aspirate, or other extrapulmonary samples if relevant. Lateral flow urine lipoarabino Manan assay. Currently, these are not available as of now, but we see that the government may be introducing this when the patients are quite sick and unable to procure sputum samples. Cryptococcal infection among adolescents, serum or plasma or blood cryptococcal antigen screening followed by lumbar puncture if positive or symptomatic. These are available for more than 10 years of age. However, if the cryptococcal meningitis suspected, we can go for these procedures. Malnutrition, we have to examine the patient for weight for height at every visit, height for age, mid upper arm circumference among children 2 to 5 years old. Then the plan for treatment after proper diagnosis, tuberculosis, severe pneumonia, severe bacterial infections, cryptococcal meningitis, and severe acute malnutrition according to WHO guidelines. Then optimize treatment for rapid antiretroviral therapy, and antiretroviral therapy counseling is also must. Prevention, bacterial infection and pneumocystis pneumonia with appropriate co-termoxazole prophylaxis, tuberculosis, TB preventive treatment with isoniazid, cryptococcal meningitis among adolescents with fluconazole preemptive therapy, and vaccinations according to the current NSM schedules. This is another elaboration. For tuberculosis, we follow the algorithm, use the following diagnostic tests to confirm TB as applicable. Rapid molecular diagnostic test, nowadays, the net is available on induced sputum, gastric aspirate, or other extrapulmonary samples if relevant. Ideally, 2 samples are sent for these samples. Lateral flow urine lipoarabino Manan assay be available as per the guidelines. Recent data shows that this TB-LM is more sensitive and specific when it is being done, as the published literature shows. Cryptococcal infection among 10 years, serum or plasma or blood cryptococcal antigen screening followed by lumbar puncture if positive or symptomatic. Malnutrition, weight for height, height for age, mid upper arm circumference among children 6 months to 5 years of age. The other previous slide showed 2 to 5 years of age, but this one we are following this 6 months to 5 years of age. Treat TB, severe pneumonia, severe bacterial infections, cryptococcal meningitis, and severe acute malnutrition as per national guidelines. Optimize rapid ART therapy at earliest or before discharge in hospitalized children with optimal regimens. We could to start ART therapy at the earliest because if we plan for follow-up, they may be lost. ART therapy, preparedness, and adherence counseling. It should be emphasized at every point. Bacterial infections and pneumocystis pneumonia with co-termoxazole prophylaxis for the prevention. TB preventive treatment for children above 1 year of age. Cryptococcal meningitis among adolescents. Fluconazole preemptive therapy for adolescents. This is available in the NACO guidelines. The appropriate nutritional counseling to prevent malnutrition and along with proper vaccinations. How do we assess? After assessment, we're going to screen and we're going to perform trials. Assess the child for general signs of serious illness. Is the child able to drink or breastfeed? If the child is breastfeeding. If the child is vomiting everything. If the child has convulsions. Is he lethargic or unconscious? Or is there a stridor in a calm side? Then screen. After assessing these few points, we're going to screen the child for severe acute malnutrition, edema of both feet, weight for height or length in a proper chart, WHO chart less than 3 Z scores, or mid upper arm circumference less than 11.5 centimeter, and any one of the following medical complications present, not able to finish ready to use therapeutic food, then breastfeeding problems. So we're going to screen the child for severe acute malnutrition. Then how do we assess the child with HIV for advanced disease management? CLHIV less than 5 years of age with newly diagnosed HIV infection, or those re-entering care after treatment interruption when they are identified. This can be started from the care coordinator or an experienced nurse. We do the 4S TB screening. Any occurrent cough, fever, or weight gain is reported weight loss. What are they? It will become in the next slide. History of contact with a known case of tuberculosis, especially during the last 2 years. If the answer is yes to any of them, we investigate. In the field situation, it can be done by the medical officer first with a chest X-ray, then the sputum or induced sputum, gastric levels for NET, if the facilities are available, and if the TB lamp, if the CD4 per count is less than 200 cells per cubic mm, or WHO clinical stage 3 or 4. Then the nurse may consult with the medical officer, where he will check for danger signs, not able to drink or breastfeed, vomiting or everything, convulsions, lethargic or unconscious, stridor in a calm side, and he will also examine for fast breathing, this tachypnea, chest indrawing, sunken eyes, skin pins, retracts slowly. This fast breathing and chest indrawing for the pneumonia, sunken eyes and skin pins for severe dehydration, fever and the temperature more than 37.5 for possible sepsis, stiff neck and a bulging anterior fontanelle for meningitis. When he finds these symptoms, he will refer the patient for further management of acute conditions, including hospitalization and a referral to higher centers. Continuing from the previous slide, medical officer in consultation with the pediatrician check for severe acute malnutrition and any of the following: presence of medical complications, any danger sign, severe dehydration, pneumonia with chest indrawing, not able to finish ready to use therapeutic food, or breastfeeding. If they are present, refer the child for further management of these to hospitals or other higher referral centers. When it is not there, medical officer's decision, child less than 5 years with any danger sign or severe illness like pneumonia, active tuberculosis, diarrhea, dehydration, or severe acute malnutrition, who clinical stage 3 or 4, CD4 less than 200 or low CD4%, unsuppressed viral load more than 1,000 copies per ml. I'm sorry for this. There is one line. Excuse me for a minute.
Sir, you're on mute.
Yeah. Sorry for the interruption. Continuing from the previous slide, when it is the previous slide, starting from this, the child less than 5 years with any desert signs, the WHO clinical stage 3 or 4, CD4 count less than 200 cells or low CD4% and suppressed viral load more than 1000 copies per ml. When it is no and yes, we go to the next slide. When it is yes, advanced disease management package should be activated with the initiation of co-tamoxifen prophylaxis, treatment for opportunistic infections, preparedness and counseling of child and caregiver on ART and nutrition. Rapid ART initiation should be done at the earliest when the clinical condition has been stabilized. Treatment for tuberculosis, isoniazid preventive treatment for children above 1 year of age as per national guidelines. Immunization as per national immunization schedule and intense follow-up should be advocated for when the other above features were present. When they are not present, standard package of care should be made available. Treat and stabilize active opportunistic infections and severe acute malnutrition. Initiation of co-tamoxifen prophylaxis. Preparedness counseling of child and caregiver on ART and nutrition. ART initiation before discharge. This should always be done. And the counseling should be emphasized again and again. Then TPT or isoniazid preventive treatment for children above 1 year of age as per national guidelines. Immunization as per national immunization schedule and intense follow-up. Please note TB lamb screening test is not currently available in the program. Now this screening for tuberculosis, as it is one of the common diseases which has got a major morbidity and the mortality. Intensive case finding of tuberculosis among CLHIV with the 4 symptom screening. Whether the child is having current coughing episodes, whether he has fever, whether there is poor weight gain or reported weight loss, history of contact with a known case of tuberculosis, especially during the last 2 years. Reported weight loss of more than 4-5% since the last visit. This intensive case finding algorithm is obtained from this chapter. When these 4 are present, we investigate for tuberculosis and other diseases. Tuberculosis is confirmed, treat for tuberculosis, no TB, follow up, assess, and consider IPT, isoniazid preventive therapy if there are no contraindications. Other diagnosis, give appropriate treatment, and consider IPT if no contraindications. So current cough may be due to pneumonia. When these symptoms are not present, assess for contraindication to IPT. If there is no contraindication to IPT, give IPT. Is there any contraindication? Defer IPT. Screen for tuberculosis regularly at and each encounter with a healthcare worker or a visit to health facility. I think this must have been covered already in the previous session. The tuberculosis may also be pulmonary tuberculosis and extrapulmonary tuberculosis. How do we differentiate between these two, or how we assess between these two? Clinical features of pulmonary tuberculosis, just to recapitulate: fever, cough, failure to thrive, weight loss more than 5% of body weight as compared to highest weight recorded in last 3 months, or weight gain or no weight gain in last 3 months, contact with a tuberculosis, contact with a person with any form of active tuberculosis within the last 2 years. So weight loss is more than 5% body weight as compared to the highest weight recorded in last 3 months. For the extrapulmonary tuberculosis, lymph node enlargement anywhere, headache or confusion, which may give rise to suspicion for neurotuberculosis, backache, joint pain, spinal deformity for bony tuberculosis, chest pain, tightness in the chest, respiratory distress, which may point to pericardial or pleural, abdominal pain, swelling, discomfort, and respiratory distress for abdominal and peritoneal tuberculosis, and a history of contact with a known case of tuberculosis. So these are the clinical features for extrapulmonary tuberculosis, and we have got to have our suspicions. What are the diagnostic tools available for TB among children? First, we have got to do a thorough clinical evaluation. Then we order for a X-ray. Then we can take the samples for sputum, gastric aspirate, gastric lavage, induced sputum, bronchoalveolar lavage can be used for CBNet. Usually 2 samples are sent. Sorry. Gastric sampling is done in children less than 3 years of age or who is not able to expectorate sputum. 2 early morning samples of gastric aspirates through nasogastric tube are to be collected. TST or Montus test using standard tuberculin as an adjunct tool in the diagnosis of TB may be offered, but most of them we find that they are negative. TU-PVD solution injected intradermally into duration is read between 48 and 72 hours is available in most of the hospitals. Ultrasonography for abdominal tuberculosis, high needle aspiration cytology, or especially for cervical lymph nodes if they are well enlarged, accession or biopsy of a specimen, for example, for these lymph nodes, fluid for cytology from the involved side can also be used, like for example, pleural or pericardial or the peritoneal fluid. If they are available, we can use ultrasound-guided fine needle aspiration and send a sample for all the other things. Neuroimaging can be used for CNS tuberculosis. So these are the various diagnostic tools available for diagnosis of tuberculosis. Then, how do we screen for cryptococcal disease? Main difference in the package of care for children as compared with adolescents and adults. Routine cryptococcal antigen screening and a preemptive therapy are not recommended for children less than 10 years of age. However, if children However, if a child less than 10 years of age presents with signs and symptoms of meningitis, cryptococcal meningitis should still be considered and appropriate investigations and treatment for this should be implemented. Then screening for malnutrition. Severe acute malnutrition is common at HIV diagnosis. This is also what we see in our pediatric population here in Nepal also. All children should be assessed for presence or absence of malnutrition at the time of HIV diagnosis and during each visit. Anthropometric assessment is most important, like height for age, the height for length, weight for length, and the mid-upper arm circumference. Then what are the modalities for treatment of tuberculosis in CLHIV? The various drugs being used in the treatment of CLHIV with tuberculosis, they are isoniazid, rifampicin, etamitrole, and pyrazinamide. These are the various doses. We won't go into detail. It is available there in the booklet. These are the daily dose regimen. Initially, for the intensive phase, 4 drugs are used, and for the continuation phase, 3 drugs are used in the current NTP guidelines. And the treatment of drug-sensitive tuberculosis in CLHIV. This slide depicts the ART drug regimens for CLHIV during co-treatment of drug-sensitive tuberculosis. 4 drugs for 2 months, ICRZE, and 3 drugs for 4 months. These are according to the various weight and age, less than 2 kilo and age below 6 years, weight between 20 to 30 kilo and between 6 to 10 years and above 30 and above 10 years. Recommended regimen in TB co-infection is FDC of abacavir, lamivudine twice daily as per weight band, lopinavir, ritonavir, and the super boosting with additional ritonavir twice daily as per weight band. Super boosting is being offered because rifampicin is decreases the viability of this protease inhibitor. Not only protease inhibitor, for this dolutegravir also. Then the FDC of or between these 20 to 30 and 6 to 10 years, FDC of abacavir, lamivudine twice daily as per weight band, and the dolutegravir 50 milligram twice daily. And for above 30 kilo and above 10 years also, same thing. And Here we give additional dose of dolutegravir 50 milligram after 12 hours. Scenario in a TB treatment in CLHIV on protease inhibitor based ART, rifampicin suppresses bioavailability of boosted PIs like this lopinavir, ritonavir, which is in commonly used. However, rifampicin, an effective anti-TB derivative of rifampicin group, does not inhibit effectiveness of these drugs. So, anti-TB treatment initiation should be done as soon as TB is diagnosed, even in patients on PI-based ART. If substitution of rifampicin with rifampicin cannot be done immediately, one should not consider super boosting of PIs. 1:1 proportion as in children. With higher ritonavir dose in adults, toxicities will be very high, and hence these are not recommended. Rifampicin availability must be ensured. In a scenario where TB treatment in children living with HIV on protease inhibitor-based ART, super boosting with lopinavir with ritonavir is recommended in children in proportion of 1:1. If age more than 6 years and weight 20 kilo, replace boosted DPI with DTG, given twice daily dose. So more than 6 years and weight more than 20 kilo, replace PI with DTG. This one we'll skip. Now, coming to the optimize and prevent. Rapid ART initiation within 7 days of diagnosis is a priority, but children who require hospitalization for severe illness, like severe acute malnutrition, tuberculosis, meningitis, or other illness, they need to be clinically stabilized first. Then when the patient has been stabilized, initiating ART is encouraged as part of the child's hospital admission, because early recruitment is very, very important. And the linkage is also important, because if we call them for follow-up after discharge from the hospital, they may be lost to follow-up. Ensure linkage to the facility in which the child will receive ongoing HIV care on discharge, which is critical. Then you prevent, especially for pneumocystis, cerebral pneumonia. This slide shows the protocol for cotrimoxazole desensitization in adults and children. Although cotrimoxazole is the preferred drug for this PCP prevention, some of them, they may be hypersensitive to this cotrimoxazole. So in this situation, the cotrimoxazole is usually started with the lower doses in this day 1, 2, 3, 4, 5. So this is also available. CPT is available in suspension as well as in tablet form. Now, going to start CPT prophylaxis. In the group, all HIV exposed infants and children from 6 weeks of age or at first encounter with health services, and when to discontinue. HIV infection has been reliably excluded by a negative antibody test done at 18 months or more, regardless of ARV initiation. Then for those HIV infected children up to 5 years of age, regardless of WHO stage or CD4 counts or CD4 percentage, at 5 years of age, when clinical or immunological indicators confirm restoration of the immune system for more than 6 months in a child more than 5 years of age with a WHO stage 1 or 2, CD4 count more than 350 cells per cubic mm on 2 occasions, not less than 6 months apart. This is up to 5 years of age. We plan to stop at 5 years of age when these conditions are fulfilled. In those children with more than 5 years of age, when to start? WHO stages 3 and 4, regardless of CD4 count or CD4 count less than 350 cells per cubic mm, regardless of WHO staging. Here also same thing. When clinical or immunological indicators confirm restoration of the immune system for more than 6 months in a child more than 5 years of age with a WHO staging 1 or 2, CD4 count more than 350 cells per cubic mm on 2 occasions, not less than 6 months apart. Then, as a secondary prophylaxis after completion of treatment for PCP pneumonia, less than 5 years, we do not stop. More than 5 years, when the patient has achieved a WHO stage of 1 or 2 or CD4 count more than 350 cells per cubic mm on 2 occasions, no less than 6 months apart. This is for the prevention of PCP pneumonia. This slide shows the weight and age-based dosing for co-tramadol prophylaxis for PCP prophylaxis. This one we will not go into detail. This is for isoniazid preventive treatment in children living with HIV. What are the indications? CLHIV more than 1 year of age who are 4S negative are unlikely to have active tuberculosis. Infants less than 12 months of age living with HIV who are in contact with a person with tuberculosis and who are unlikely to have active tuberculosis on an appropriate clinical evaluation. So this one is there. The dose is 10 mg per kg per day given for 6 months. For adults and adolescents, isoniazid 300 mg plus pyridoxine 50 mg is given for 6 months. These are the various doses according to the weight range. There are some contraindications to IPT. When the patient has active tuberculosis disease, of course, we're going to treat the condition. Active hepatitis, because isoniazid is hepatotoxic. Signs and symptoms of peripheral neuropathy. Concurrent use of other hepatotoxic medications, it is going to compound the problem. Contact with MDR tuberculosis patients, CLHIV who have completed drug-resistant TB treatment. So I think this is the end of this slide with this preventive treatment for tuberculosis. Next,
thank you so much, sir.
Initiation, this will be taken up by some other faculty. Thank you, madam. Thank you so much.
Thank you so much, sir. Any questions from the participants? So we have one question in the chat box. What imaging is preferable for suspected CNS TB? Is it CT, MRI, CECT, or CE-MRI?
Yes, madam. Here we prefer CECT.
Thank you, sir. Any more questions from the participants? You can unmute your mic now. So I don't think there are any questions. Thank you so much for facilitating this session. We'll quickly run the feedback form now. Kiran sir, can we have the feedback form, please? Kiran sir, can we have the feedback form, please?
It is launched. It's working.
It's launched? Okay, sorry, it's not visible to me. Okay. Please let me know once we cover 50%. The feedback form is now visible on your screen. Participants are requested to please fill in the feedback form and answer all the 4 questions.
Hello.
Yes, sir.
Sir, my question is which neuroimaging mode is preferable in case of suspected CNS TB? For example, plain CT scan or plain MRI or contrast CT scan or contrast MRI, which is preferable actually in case of suspected CNS TB?
CCT is preferable because the enhancement is much more.
Sir, why not MRI?
MRI usually for in inflammatory conditions, our radiologists, they are saying that here we are doing CCT is better. CT is better. Contrast enhanced.
Okay, sir. Thank you.
That's in the sense, I mean, yeah, his wife, because
Kiran sir, can we conclude this session now?
disease that is contagious, they touch kar rahe, you are something again, and she need to accept that.
Thank you, sir. We'll conclude this session now.
Thank you,
Thank you
madam.
to all the participants for patient listening. The next session is on 3rd of March, and the topic is care of CLHIV post-ART initiation. Thank you.